and Wilderness and Emergency Medicine lecture series. As you can tell, I'm not Shilpi. My name is Seth Lyle. I'm going to be the vice coordinator for this board as we're transitioning from Shilpi running it to us as a international board. So we're very excited to be putting this on and to have you all here. Here are our lovely, pretty faces. And now we have a Twitter and an Instagram. You can follow us at go_WME. We'd be excited to share all of our updates and when these next lectures are happening. So our mission is to create an educational platform where interested students and healthcare professionals can explore and interact with wilderness and emergency medicine, to showcase the diverse spheres in which physicians and healthcare professionals can make an impact and inspire others to think abstractly about the ways in which we can utilize our careers in healthcare and medicine, and to create an international community of wilderness medicine enthusiasts and experts committed to promoting a diverse and culturally competent environment. On that end, I'm very excited to bring to you today's rural medicine. I hope you were expecting that. We have a great couple of talks coming up. Next week, we have Dr. Ainer talking about transoceanic rowing, which I hope to see you all for, and for several other ones coming up. Today, as I said, we're doing rural medicine. We have Dr. Steve Jameson here. Dr. Jameson received his MD from the U of MN in 1989 and finished his emergency medicine residency in 1993 at the Medical College of Wisconsin-Milwaukee. Dr. Jameson worked in a level 2 trauma center in St. Cloud, Minnesota for 27 years and translated to half there and half time working in rural emergency departments and teaching rural and other emergency medicine providers, physicians, PAs, and Ps. He is the current chair of the National ACEP's rural section, and furthermore has worked in dozens of rural hospitals in the US, internationally in New Zealand and China, and throwback to last week, even as a ship doctor. I'll go ahead, Dr. Jameson, you can take it away.
All right, very good. Thank you, everyone. So I'm curious, is this, is the audience all medical students? Or are there some faculty, or are there other people besides medical students, the residents and that as well?
Yep, there's a happy mix of med students, professionals, healthcare professionals, attendings, residents, and some pre-meds. So a happy mix of everyone.
All right, well, very good. Well, I will screen share and we will go ahead and get started. Can you see my screen okay?
Looks great.
Good deal. All right. Well, as Seth mentioned, my name is Steve Jameson. I'm an emergency physician, been practicing for a number of years, specialist in emergency medicine. And I want to talk to you today about rural medicine, the workforce needs and projections, and about rural medicine in general. This is going to be a talk about clinical medicine, about rural practice, and we're going to really even touch on the topic of the business of medicine as well. So I will jump into that. We can make this a bit informal if it's not too difficult. Seth or one of the of our co-hosts here will be monitoring chat, and if you need to ask a question along the way, I can stop and answer. Otherwise, you can hold them till the end, and we'll have time at the end to talk about a few things. So I do have a disclosure for a potential conflict of interest. I am a co-editor, an author, and a co-owner of a program called Emergency Medicine Core Training. It's for training providers that are new to emergency medicine, those that haven't gone through a formal emergency medicine training program. So family physicians or internists or surgeons that are looking to practice emergency medicine or transition from their current practice can go through a program such as this. And I'll talk about other steps to become a rural medicine physician. And I'll talk to you about that in the business of medicine side. But some of the work, much of the work we'll be talking about and the experiences come from that program, and I'll explain that as we go along. I laughed at this picture in your brochure. I love it. This seems to be the perception of rural emergency medicine. I got a pretty good chuckle. It looks like rural Vietnam, maybe. It would be my perception. That's hardly rural medicine in the United States. I was a bit jealous of your other promo pics here. mountain medicine, disaster medicine. Those are all very sexy topics. Rural medicine is being misrepresented here, I'm telling you. So I'm hoping to sway your opinion of rural medicine. It's not practicing in a hut. There is a lot of exciting stuff. And in fact, rural medicine is more challenging than urban medicine. And I'll tell you why that is the case as well. But a spoiler is you're alone and you're the only one there to do it. So you don't have the backup of everyone. So rural medicine, hugely important, under-resourced, but not quite as under-resourced as depicted in your picture. So, all right, this is a more realistic picture of rural emergency medicine or rural medicine in the United States. This is a facility or an entire old hospital in Minnesota. This is one that's in Wyoming. This is a more traditional hospital. This is the entire hospital. It's about 4 rooms deep. It's 3 stories. But this is a traditional kind of rural hospital, and it would be the clinic and it would be everything that you would see patients at, and they go directly from clinics up to the floor. The emergency room was typically just that, an emergency room. There was a time in the 1980s and 90s that
Excuse me, Dr. Jameson, you've muted yourself.
yeah, somehow that I noticed that happened. Sorry. I wasn't even touching the mouse. Anyway, some were very offended in emergency medicine in the 80s and 90s that you would call an emergency room an emergency room. We wanted to be called an emergency department. And an emergency room would refer to these rural facilities that had just a single room to see their emergencies. We were departments. We were the emergency specialists. And then the show ER came out, and people were like, well, no, actually, maybe emergency room is okay. That's in people's common lexicon. And maybe that is kind of a cool thing to have. And maybe we don't want to be referred to as ED or erectile dysfunction. So ER actually has been embraced once again, but you'll see both abbreviations used. All right, next. In rural medicine, there are critical access hospitals, and there are specific definitions of those in the United States. Let me just jump back a second. Yeah. There are specific definitions of those in the United States. They have less than 25 beds typically, and they're spread throughout the United States, and in larger populated areas where they have more beds, they can't be called a critical access hospital, but they still are located in rural environments. But there are 1,350 critical access hospitals in the US, Alaska, and Hawaii. And there is a map here. If you're interested, you can pull those up and see where those are located. So who works in rural emergency departments? Traditionally, the local primary care providers would staff the emergency department. And this was prior to the 1970s. But in the early part of the 20th century, really, there weren't any specialists except for surgeons and pill doctors. You know, you basically got lumped into 2 groups. If you weren't a surgeon, you were one of the pill doctors. You're just one of the regular medical doctors. The American College of Surgeons was actually established in 1912, and that started an explosion of people specializing, including into OB-GYN a few years later, and then various surgical subspecialties and all. Emergency medicine kind of came at the tail end of a wave of major specialties, and was developed in 1970 when they had their first residency started. And since then, there's been quite a growth in emergency medicine in popularity and in numbers because of a perceived lack of emergency physicians throughout the United States, and largely because of rural America. There is a real push that every emergency department should have an emergency physician in it, and there's been a 28% growth in emergency medicine residency slots in the last 10 years, to the point now there are right around 200 programs, and they graduate over 2,000 residents in emergency medicine every year. And a workforce study was just completed last year in emergency medicine, and revealed that in a 10-year follow-up from 2009 to 2019, emergency physicians have really just saturated the urban setting and not really moved rural at all. And that makes sense. You know, you go through a residency at a high power urban trauma center, and that's where you want to practice. It's where you get to use your entire scope of your practice, and you see patients frequently, and you see the high volume and the repetition. And that's just what you get drawn to. In rural practice, you will see much of the same thing, but you'll just see much smaller numbers. And that setting hasn't traditionally attracted emergency physicians there. So very small numbers have gone to that. So let me move to the next. So who is working then in the urban and the rural settings? So in the urban areas, emergency departments are largely staffed by emergency medicine trained and boarded physicians. Advanced practice providers are commonly used as well to help see patients, and they are sometimes just relegated to fast track areas. But in many places, like ours in central Minnesota, we have a level 2 trauma center. Our APPs, PAs and NPs, see the entire breadth of emergency medicine. The emergency physician has to go for all triage level 1 patients, which is your most acutely ill patients. But short of that, the PAs and NPs see a wide variety of patients. They do a number of procedures, and we have some that have worked with us that have essentially done 14-year residencies in emergency medicine because they've worked very closely with us and have become very skilled in emergency medicine. As far as the rural ED workforce, traditionally this was staffed by local primary care physicians. That's not the case today. With health systems taking over large areas and taking over rural critical access hospitals, using them for their swing beds and that sort of thing, and taking over the management of those facilities. And I don't mean to indicate that that's a bad thing. It's actually a way to have a highly integrated system, which is good. But in doing that, typically the local family physicians are not any longer the physician for the community necessarily. They're hired by the health system to provide a certain level of care. And those physicians don't seem to have the same commitment to the community or obligation that they need to cover the emergency department, need to cover all the on-call for their clinic, need to cover their clinic through the day. And many of them are hired then by the health system and salaried to provide that primary care. And so they've really divorced themselves of the emergency department. And this has left a void in many of these communities for providers to work the ER then. And that volume hasn't been there in availability of residents and in patients coming to those facilities. And if the local primary care physicians are not seeing them, then that void has been picked up by locum workers, and more recently has transitioned to NPs and PAs working at those facilities. And I'll get to some issues related to that. But that's been the transition of workforce in those communities. In the early days, it was anyone that was a primary provider would work there. The OB doctor, the surgeon, there were ophthalmologists that took call in the emergency department if they happened to have one in the community. If you were a doctor in that community, you did your ER shifts. So what do these rural emergency providers do? And the answer to that is they do the same thing that you do at high volume EDs, you just do less of it. But there tends to be a greater proportion of sick patients that come in. So percentage wise, you're going to see sicker patients. You're just not going to see them as often. And it's likely that, you'll see them sporadically. But unfortunately, when it rains, it pours. And if there's a multi-car accident, you're going to see all of those patients. I was working in a rural facility one time and a fire broke out at an apartment building, and suddenly there were 8 people that came in. One was someone who was a heroin addict and actually started the fire accidentally, had no IV access, had burns on his body, and was traumatized besides, and had to put a line in him. And then a woman who was 8 months pregnant jumping out of a 2nd-story window because she couldn't get out in the hallway. So she had potential abruption of her placenta, and suddenly, and then you've got 6 others. So you've got to triage them yourself, and you've got to get through all those patients. So in the rural setting, you don't have the backup that you do at other facilities. So when that would happen at my hospital at a level 2 trauma center, I've got 3 other colleagues that can come in. We've got our PAs and NPs that could see some people, and we make quick work of it. But when you're working alone and you have limited number of nurses as well, it can really be a challenge. So it's actually more of a challenge to work rural than to work in a very comfortable urban setting, I would argue. Traditionally, it had been anyone could be the EM doc, but at the rural facilities, you might not only be the rural physician, you might be the hospitalist, you might be the OB doctor on call. You'll likely need to do all your own procedures. You're not going to have interventional radiology to do your paracentesis or thoracentesis for you. So those are procedures you're going to just have to do. And you do not have ready access to your consultants, although that is changing with telemedicine. So what I want to do is, since we have a lot of medical students, you've done some rotations and things, I want to walk you through a few cases that I've seen rural and others, so you can kind of see a mix, and then we'll come back and talk about staffing and things. So here's a 12-lead ECG of a patient that came in feeling weak and a little lightheaded, and his pressure is running around 80 to 90 systolic. He's diaphoretic, no chest pain, but has a history of coronary disease. This 12-lead ECG is a wide complex tachycardia, rates about 170s on the monitor. And he's got a pacemaker that actually has a cardio defibrillator in it, but it's in case he would have a VFib arrest. And it was just under his threshold for shocking him, which was 180 beats a minute. So this had been going on for about half hour, 45 minutes, and this guy is a little sick with it. So what do you want to do with this guy? You're the rural provider. Do you call a helicopter? Do you call an ambulance? Do you want to do some intervention, give him medications? So I'll show you what I did. we decided to cardiovert him. I don't know if any of you have seen a cardioversion before, but he is getting sedated with propofol. He's awake.
Deep breaths for us, okay? There we go. Any evidence? Synchronize 120. Yep.
So you want to make sure that he's well sedated.
How you doing? Talk to us. Everybody clear? Take a deep breath. Yep. Charge. Hold the charge button. There you go.
At the Rural Hospital, they make me run the cardioverter, which is a mistake. So
Take a deep breath for me.
I guess we can't see on the monitor, but he goes back into a normal sinus rhythm. He's a little sedated from his propofol, so we bag ventilated him a few breaths, and he woke up, didn't recall anything. His pressures came up to 110 systolic. His symptoms all resolved, and he felt much better. It didn't keep him from being admitted to the hospital. He still needed to get observed and taken care of, but he was in much better condition when he got transferred to the larger hospital than when he came in. Had we left this guy in that rhythm and let him just go by ambulance for 90 minutes down to his next hospital by ground, he could have deteriorated into a VFib arrest, which can happen with wide complex tachycardias. So you do need to take some initiative and do some of those things. You can hear in the background there too, they're telling me to run the cardioverter. It's like, I don't do that, the nurses do. I just ordered 200 joules, but they make you make it happen there. So they're instructing me on how to use the machine. Other things that you see, this is a nasty case, guy that, well, one dropped into a fire on the right. He was doing something, and anyway, he dropped into a fire and got burned over a good part of his body. This is actually a different patient, was a gasoline injury, who got escharotomies because we couldn't ventilate him. And he's got a central line up here and really sick people. So you see these same, again, people rurally that you see in the big setting. This is an example of one from a room camera, and all these are with patient consent after they've woke up, or I've followed up with all of them, so they've said that we could use their images for educational purposes. But this is a guy that I'm intubating that came in after a motorcycle accident. But notice you'll have maybe 2 nurses, you'll have your paramedic that brought the guy in hang around to help you. And he's, helping with the bag ventilation and managing the airway. I'm doing an intubation. You've got another tech that's there that's, running. She's squeezing a bag of fluid because he's hypotensive, the sides. So it's airway, breathing, circulation, and you have to manage everything. So you don't have the luxury of having 20 people around the bedside and a trauma bay and a surgeon and everyone readily available for you. This guy ended up having a pneumothorax, which is why in part he is hypotensive. He developed a tension pneumo while we're working on him, and had to put an immediate chest tube in once we secured his airway, but he came in not breathing adequately. He had COPD. So you got to move quickly and respond to situations, that sort of thing. Here's a guy, I'll play a video for you. See if you can guess what he's in with. They're putting an IV in him. Oops. So what do you think that is? You notice how he's deep breathing? We call that Kussmaul breathing. And the first thing you want to do when people come in unresponsive is get a glucose level, and his was greater than 600, and he was in DKA, and we later found out he was diabetic, and he was profoundly acidotic. So I followed up with this gentleman a day or two later. He was sitting up in bed having yogurt and and looking very good. DK is probably the most gratifying things that I've ever taken care of in internal medicine and that sort of thing. The turnaround in these patients over the first 12 to 24 hours is just astounding. It's just medically very gratifying, and it is just such basic science. The applications of basic science to the clinical management is just really cool, and I'm kind of a basic science junkie. But it's very cool. Notice we're not intubating this guy, even though he's breathing hard. You might think airway, breathing, circulation. The last thing that you want to do is interfere with this guy's Kussmaul breathing. He's compensating for his metabolic acidosis by hyperventilating, and you do not want to stop that. That's been an error of many novice providers, and you can immediately turn this into a disaster. Whereas if you just let him breathe and you give him fluids and then give him insulin and check his electrolytes and make sure that he's not super hyperkalemic or hypokalemic, and just monitor all well, he will recover very good. And he did. He had a great recovery he was waking up within just a few hours, even before he went to the ICU. And again, was sitting up and looking very well within 24 hours. So very cool case, but his pH was 6.85. So he's essentially exhausted his buffer reserve in his body, and one more hydrogen ion being produced could tip him over the edge. So these are patients that get treated very aggressively, which is why they're working on the IV access there with ultrasound, because he was so dehydrated and all. Let me play another one for you. This is a guy that is a BMX rider. I'll kind of jump through this a bit. But he crashed his BMX bike and comes in with left chest pain. We did a chest x-ray on him. He's got a normal lung inflated here on this side. That's the edge, that's the lung edge here. You can see he's got a huge pneumothorax. And the next thing that happens is he goes on to develop a tension
When we
pneumo.
get you in bed, we're gonna put a tube in there real quick.
So what we do is we prep his chest. I don't know if any of you have seen a chest tube put in before.
We'll document the insertion of it.
So they're giving him, we're trying to move quickly through it. He's a really tough guy. We're giving him pain meds on the other side. We're sedating him a bit. You want to go at about the fourth intercostal space, which is about the nipple line. So I anesthetize just below that, and then you tunnel up under the skin.
Hanging a burn.
Well, that's probably is-
Don't.
She didn't like the look of the IV insertion. So.
Right on the rib right now. Just looking about it. That's gonna smart swing. That's the rib right here. So it's gonna numb up a lot right on the rib itself.
So he's getting Versed just to take the edge off a little bit. He's getting some fentanyl. He's getting local anesthetic, bupivacaine
Hurt when we go in there, so.
on his rib. So listen for the rush of air. It's into the chest.
Yeah, great. Your breathing's gonna get a lot better.
So you want to make sure the lung isn't adhered to the chest wall and all. That's clear.
No, give them two.
So then you pass the chest tube in.
They're high.
So that's the chest tube after it's in. You hitch it up to suction. Whoops. Hitch it up to suction. You sew it in.
What's that? It all gets better from here, yeah? Yeah.
So he tolerated that very well. He's a tough dude. You wrap some gauze, Vaseline soaked gauze around it.
Excellent.
Put some gauze under it, gauze
Nice to
pads.
see this live.
Secure it.
We mean that in the nicest way possible.
Yeah, next right.
So that's putting a chest tube in. So his follow-up chest X-ray revealed that his chest tube in good position, lung well expanded, and he did very well after that. If you let this go and send him on from your rural facility, he will go on to develop tension pneumothorax. He'll become hypotensive and he could die from this. So these are the things that you have to intervene with when you see that size pneumothorax. If you were to fly him in a helicopter, that will collapse even more rapidly. Other things we see are young kids with fever. This is spinal tap. They performed on I don't know, this baby's just a week or two old, who came in with fever and looking for evidence of meningitis. So even the youngest of ones, parents are trusting you with their precious child and they're depending on you to take care of them. And it's up to you to be well prepared to do that. And if you haven't had adequate training in managing kids, you're really doing them a disservice and you're really being disingenuous to the profession and not being adequately trained to manage them. And because there were family physicians and local primary physicians that weren't entirely prepared to do emergency medicine, in the 90s, there were a couple of physicians. One was an emergency medicine faculty, Ernie Reese. Another one was a community family physician, Daryl Carter, who developed a program called Comprehensive Advanced Life Support. It was really probably the first program besides like ACLS and ATLS that really looked at rural, though specifically, and said, we need to have a program to help these local physicians be able to manage these more critical patients, the more critically ill. And so they came up with a program that went through scenarios, and they actually brought the nurses and the physicians from these rural hospitals so they could have a team approach in managing these patients, and everyone would know their role. So it's important that the nurses know as well how to manage the trauma patients and what their role is going to be. And so they developed this comprehensive advanced life support, and it's really scenario-based learning. And that model was fine when it was physicians. Physicians had gone through at least a 3-year residency and are very clinically adept at taking care of patients. They just need a little refining on managing specific emergency patients, and particularly those patients that are critically ill. And that's what the CALS course set out to do. So how do these providers then prepare to work there? Well, with the model changing, with PAs and NPs working at these rural facilities and sometimes going there directly from their PA or NP program, unfortunately, they are not prepared to see particularly ill patients. And they're not particularly adept at seeing a broad range of patients, even people with minor eye problems or, you know, um, gynecologic problems, OB problems, even evaluating abdominal pain, particularly, you know, chest pain and potential acute coronary syndromes. They really don't have that experience that physicians had, at least going into and clinically managing patients. So the ACEP, American College of Emergency Physicians, put together a rural task force last year in follow-up to 2 previous rural task forces and looked at best practices. They looked at what was required for onboarding right now. And it was found that about 85% of emergency departments only require ACLS, ATLS, and a PALS course, which is the Pediatric Advanced Life Support, to be credentialed, which is absurd. There was no minimum standard for onboarding, and we've had PAs and NPs now graduating for more than a decade and going to work in these environments directly from their programs. And it's been a real tragedy in what we've seen transferred into our facilities. I can tell you by experience, and there is beginning to be even some med mal experience in that way, that the providers that are going there are not getting experience at a high volume facility first. There are many that are getting recruited right out of their programs. And that's just found to be woefully inadequate. And the American Academy of Family Practice agrees for family physicians as well. But SEMPA representatives for the PA programs and AAENP, particularly the NP program, agrees that there needs to be training beyond their own programs before they can work in an emergency department. And you can see the sorts of things clinically that we're seeing. And how can you expect someone who's gone through an abbreviated med school like a PA program and even a more abbreviated training program, an NP program, to be able to manage those cases? And I'm sure many of you are thinking, wow, you know, I better get some more experience and really get into a residency in order to be able to manage that sort of thing. So the Rural Task Force came with some recommendations that should be a minimum standard, since this doesn't exist. And it's crazy that it's gone this far. The cart has gotten ahead of the horse with regard to allowing PAs and NPs to work in this environment and not have that experience. But that's because emergency medicine evolved that way. It was primary care physicians initially working in that environment. It was whoever could work there was working in rural ERs. And the volume was low enough that, you know, you could see them one at a time. There was availability perhaps of a surgeon that could help you out at times, a local pediatrician you could just consult once in a while, and they work collaboratively. But now there are these PAs and NPs working quite independently at these facilities, and they've kind of just moved into this role because that's what family physicians did, was move into that role. But they are not equivalent to a local primary physician. Their training is much, much more abbreviated. So they need to have a minimum standard. And so ACEP recognized that and is looking to develop that. And that's why we came up with a 5-step process that mimics a best practice done by the Mayo Clinic. And that includes some emergency medicine foundational training. So a broad exposure to the field of medicine, airway training and experience, simulation, which is like that CALS course. They need to have experience in a high volume ED with emergency medicine trained physicians for a period of time. And then they need to have telemedicine support and oversight. There are EM fellowships for physicians. There are postgraduate programs for PAs and NPs in emergency medicine. Those certainly would be advisable to do before practicing emergency medicine. But this is all about improving patient care and safety, and that's why we put that together. So your take home for the rest of you as physicians, and many of you will be going into primary care, I have this to say, that during your training, see as many patients as you can in your residency while you're under the supervision of your faculty. That's the most important thing you can do. See as many people, see sick people, and be prepared to manage sick people. Be a specialist in a particular area. And you need to be an expert and well-read no matter what your specialty. Just being a doctor is not going to be enough anymore. If you are planning to do primary care and you think you're going to do annual exams and routine health checks and that sort of thing, that's going to be a thing of the past. You will be supplanted by PAs and NPs, and that's happening very broadly in the US in primary clinics. They're much less expensive and they can do protocol-driven care very well. And in fact, you probably don't even need a PA or NP. You probably just have your nurse do much of that. But for billing purposes in the US, it has to be a provider. And we've given a lot of ground up as physicians for PAs and NPs to do this just because it's been so efficient. And that gets into a lot of the politics of medicine. But just be prepared yourself to see sick people. Because if you've gone through 4 years of medical school and 3 years or 4 or 5 or more years of residency, you better have set yourself apart from your PA-NP colleagues. You will work with them collaboratively, and I would learn to work with them collaboratively. They aren't the enemy. They are your colleague, but you need to be a leader of the team as the physician. So establish that, and again, be well-read and be the expert in the room because you've had the extra training. So that's all I had for today in the presentation. If there are questions, I'd be happy to field them.
Yeah, thank you so much, Dr. Jameson. That was amazing. I think I speak on behalf of everyone when I say thank you very much. We do have some time for some questions, so if any of the participants have a question, just throw it in the chat and I can read them out to Dr. Jameson. So for starters, how do you foresee advances in technology changing the way that we deliver care in a rural or remote setting?
Well, it's interesting. We did a survey of rural hospitals on the availability of modern technology, including video laryngoscopes, ultrasound, devices for doing cricothyroidotomies and other procedures, the trays and equipment available. And we were astonished to see that those facilities were about as well equipped as our urban counterparts. So as far as equipment availability, it's all there. Unfortunately, the training for the physicians to use that equipment has not been established. So you might have someone there with this pile of equipment and technology, but not be equipped to use it. But other technological advances clearly are telemedicine. And not just tele-emergency medicine, tele-stroke is huge and taking off. And it helps facilitate transfers to larger urban facilities and helps to manage some of these very sick patients. When patients are admitted to the hospital, there's even tele-ICU. So now these patients are even staying at rural facilities. In the COVID pandemic, instead of transferring all these patients to the urban setting, many of these rural hospitals really stepped up and kept those patients at their hospitals. And through telemedicine support, they were able to be managed by ICU experts at the larger hospitals. And it wasn't until they either needed to be intubated or be on some other therapy other than just some high flow oxygen that they would get transferred. So those technological advances have been huge. And and COVID has advanced telemedicine at least a decade and is going to advance teleeducation. I'll guarantee that as well. And the universities are scrambling to fall in line in that regard.
Yeah, perfect. I think a few people have kind of been asking about how a student or someone in their medical training could see what rural medicine looks like on a day-to-day basis, especially if they're living in an urban area.
Well, there are shadowing opportunities in all settings, but those have really been limited. For medical students, I think they would make exceptions. So if you have the time to do that, it's probably a good idea to find a rural facility, a rural primary physician, or an emergency physician, and spend some time in that setting. And I guess it depends where you would be. Where you're at. If you just drop in a rural hospital, depending on the size, it may be hours before you see anyone though. So the little snippets that I gave you here are a sampling of some of the critically ill patients you'll see.
Yeah, and what sort of specialties practice in rural areas? I know you've talked a lot about emergency medicine. How common is general surgery per se?
Yeah, it depends on the size of the hospital, and it depends on the community. But at larger urban area or larger rural areas, you'll have a number of specialties. OBGYN is one in particular, though, that even smaller rural hospitals that see around 3,000 or 5,000 patients a year will still have someone that does OB-GYN, and typically they'll have someone on call that could do an emergency C-section, which is really important because I don't want to have to do it. That would be a disaster. I have been involved in one in a life threat, but man, that would be a really bad situation. So I like to be where there's an OB doctor that can do C-sections. So OB is usually one of the first specialties that's around. Most gynecologic things we can manage, and anything we can't can get transferred and managed at a higher volume facility. Surgeons, general surgeons are quite common in rural areas. So you do have that support commonly. Orthopedics is hit and miss. Those are probably the major ones that I would say that you could see or that could help you out. But there are some very low volume places that your family physician and you in the ER may be the only one around. So you better be able to at least stabilize and then transfer.
And I guess going off of that, is there a typical patient demographic age-wise or certain conditions that you see more commonly when rural?
The demographic rural, it tends to be older. And so they tend to have more geriatric type problems. There tends to be more farm-related accidents. It's quite common to be next to major highways, and so multi-car accidents can be a problem, particularly in inclement weather. So yeah, like I say, when it rains, it pours. You could be sitting there all day not seeing anything, and all of a sudden 8 patients are there. And then you're scrambling, going from one to another and triaging and seeing who can wait and who needs to be seen first. So.
Yeah. And then a specific question about emergency medicine residency programs. You mentioned that a lot of the residents tend to stay in urban areas. Are you aware of any emergency medicine residency programs that have a specific emphasis on more rural medicine?
Yeah, there are I think the survey that we took of emergency medicine residencies, and we didn't get all of them to respond. I think we had a response rate of about 35 or 40% is all, a little less, maybe less than a half anyway, of the residencies responded to our survey. But we asked that very question as part of the Rural Task Force this last year that ASAP put on. And about half of those programs that responded have rural rotations of some kind for their residents or some kind of rural experience. The limitation to that is ACGME, the accrediting body for residencies, only allows that, only allows rotations where you are getting where you're directly supervised by an emergency medicine physician. So you can't go rural and be with a family physician doing emergency medicine. It has to be an emergency medicine faculty at that facility, and that's just not always feasible. So even those with rural experiences, they're probably larger rural hospitals mostly, not these, so-called frontier critical access hospitals that see very low volumes where you will be the only one taking care of someone. But about half, roughly, of residencies have an experience. I can tell you specifically the Mayo Emergency Medicine Program has that experience, and in some smaller facilities or emergency departments. And there are facilities, or I should say there are residency programs looking at waivers to the ACGME requirement to allow for tele-emergency medicine supervision by a faculty member, and that may be ongoing. I can tell you when I did residency, moonlighting was more common. I did a 2-3-4 program, so I did an internship. I did an extra anesthesia rotation during my internship. I had done one during medical school as well, so I felt good about airway. I had done some intubations on patients outside of that OR as well. I had done a number of procedures. I felt good about IV access and central lines, and I started moonlighting in my first year of emergency medicine residency, which was my second year of residency. And that really got me turned on to rural medicine, and it really is a confidence builder. And I was out there practicing, not fully trained in emergency medicine, but much more trained than the other physicians that I was taking over for before and after my shifts. So that gave me solace.
Yeah. Let me see what else. How often do you feel that patients need to be transferred to a larger hospital for adequate care?
That's a good question. A very small percentage, actually. Maybe, I don't know, less than 5% probably that present to the ER really need, clearly less than 5%, I would say, need to be transferred. Unfortunately, with undertrained providers working at those facilities, we get transfers sometimes for things even as minor as a slit lamp exam. I had someone that couldn't do a slit lamp exam and couldn't figure out why someone had pain in their eye, and they had a foreign body that we simply removed and the patient went home. I've had people sent in for lumbar punctures because they couldn't perform them out there, and they were worried that the patient had a severe headache and wanted to rule out subarachnoid hemorrhage with that, and meningitis that they're worried about. And sometimes they get there for that procedure and you go, well, you don't need a lumbar puncture after all. And after reviewing them, you end up sending them home without doing anything. So it depends on who your provider is there. But in general, less than 5% of patients really need to be transferred.
So we're getting close to the end of the time. Maybe we have time for 1 or 2 more questions, but if anyone else has questions, feel free to send them through and we can always email them off to Dr. Jameson to answer if he's willing after the fact. So would an experienced nurse practice out of scope in rural setting under inadequate manpower, such as doing an intubation or prescribing medication during resuscitation?
What would they do?
What's
the question?
Would a nurse practitioner be able to practice outside of scope in circumstances with inadequate manpower, such as do an intubation or prescribe medications?
Well, nurse practitioners have a very broad scope of practice, particularly for emergency medicine, and that depends on the credentialing at a particular hospital. That's not a scope of practice for that particular NP. It's a scope of practice at the hospital. So in about half the states in the US, NPs have independent practice. They don't need a physician collaborative agreement. PAs at this point all need a collaborative agreement, although that's changing. In fact, actually, there may be 1 or 2 states where they've already done that. I think North Dakota was looking at even Wisconsin. So they may, I'm not sure if that's gone to the legislature. And that's a real political issue, the scope of practice and supervision and all. Another odd thing with NP with nurse practice is those are advanced practice nurses. And the legislature has been led to believe that the nurses are doing advanced practice nursing, and they really aren't. I mean, this is medicine that they're practicing. And really shouldn't be under the nursing board. It should really be under the Board of Medical Practice for that particular state, if you're doing medicine, in my opinion. But they really are practicing medicine. And again, the reason for ACEP stepping up in emergency medicine, representing those patients particularly, is that there needs to be a minimum standard for training for at least emergency medicine, whether you're a PA, NP, family physician, surgeon, anyone going to practice emergency medicine. There needs to be a level of competence so that we have patient safety in mind as number one. And then even provider confidence is number two.
Then maybe just one last question before we close out. What type of personality would you say is the best for practicing in a rural medicine context?
You have to be a bit of a cowboy, I guess, so to speak. You have to be ready to manage anything. You have to be an adrenaline junkie. That's kind of what drives you to emergency medicine, but that's why a lot of emergency physicians don't go rural, is because you can't get a fix enough doing that in a rural setting. But I'll challenge anyone in emergency medicine to just go work rural, and you will get your fix when they come in, because you'll be the only one managing them. So it's an exciting area when it's exciting, and it's relaxing when it's relaxing. But it can be terrifying if you're underprepared in that environment. So regardless of anywhere that you work in emergency medicine, you just need to be well prepared, and that starts with a good education. Nobody wants to do harm, and no one wants to fall in a situation where you've got someone crashing in front of you and you don't know what to do. It's always good to be able to look behind you and see you've got your supervising physician with you, or you've got telemedicine, or you've got some other specialist or support. So take advantage of that during your training years. Take advantage of your faculty when you're confident, and as you build confidence, then manage things on your own and take care of it. But when you're alone in the rural practice, it can be frightening. And the best thing you can do is just prepare. But if you're going to go do that, don't think that just because it's low volume, you can be sheepish. Because if you don't intervene on some of the cases I showed you with pneumothorax or the VTAC, or even doing an espirotomy on someone with that burn, you're not going to be able to get that patient to survive until they get to their next facility.
With that, I'd like to say thank you, Dr. Jameson, for such an excellent talk, and thank you everyone for coming. Like I said, we have some great talks coming in the next couple of weeks, so if you are not on our mailing list and you would like to be, I'm going to go ahead and post that right down here in the chat. And I just want to say thank you again.
All right, thanks everyone. Cheers.
Thank you everyone for coming. Have a good rest of your evening, and hopefully we'll see you guys soon. And Dr. Jameson, once again, thank you so much for being so gracious with your time. That was an amazing presentation.
Thank you very much. Take care. Bye.
Bye.